everyone. Thank you for joining today's Web Interface Support webinar. This series of webinars is for the Accountable Care Organizations, ACOs, and groups that are reporting data from the Quality Performance category of the Quality Payment Program through the CMS Web Interface for the 2018 performance period. These webinars will highlight important information and updates about reporting quality data and provide ACOs and groups with the opportunity to ask CMS subject matter experts their questions. During today's webinar, we will also share links to various resources and other information that will appear as announcements on your screen. Please note that these calls will only focus on reporting data for the Quality Performance category. We will not cover reporting data for the other performance categories during these calls. Now, I will turn it over to Lisa Marie Gomez from the Center for Clinical Standards and Quality at CMS. Please go ahead.
Thank you. I want to welcome everyone and thank you for joining us today as ACOs and NIPS groups prepare for quality reporting via the CMS Web Interface. Again, I am Lisa Marie Gomez at CMS and one of the subject matter experts today participating in the webinar. Joining me are other CMS subject matter experts and contractors who will share helpful information regarding the CMS Web Interface and answer your questions during the question and answer session after today's brief presentation. Today's webinar, as well as each weekly webinar, will focus on quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding promoting interoperability, improvement activities, MIPS, or quality reporting general questions. Next slide, please. So we just want to note that this slide is just a disclaimer, and information presented during this presentation is current at the time of its publication. We encourage all CMS Web Interface users to utilize the source documents and links that are provided throughout the presentation for a comprehensive representation of the CMS Web Interface content. Also, please stay tuned for any communication from the Quality Payment Program, your Medicare Shared Savings Program, or Next Generation ACO model. Next slide, please. So we're just going to go over a few announcements. So new resources have been posted to the Quality Payment Program Resource Library, including instructional videos that provide step-by-step guidance on a variety of features within the CMS Web Interface, and the materials from the December 12, 2018 CMS Web Interface Kickoff webinar. So you will find that there are a ton of helpful and useful resources that are available to you. And so please just click on any of these links. Next slide, please. So as a reminder, we would first like to remind you that the CMS Web Interface opened for testing this past Monday, January 7th, and will remain open for testing until January 18th, 2019. During the test period, you'll be able to download your sample, practice uploading data, and use the Application Programming Interface, or API, prior to the start of the submission period. The CMS Web Interface will be unavailable from January 19, 2019 to January 21st, 2019. During this time, all data uploaded during the test period will be deleted. The CMS Web Interface submission period will open for submission on January 22nd, 2019 at 10 a.m. Eastern Standard Time and will close promptly at 8 p.m. Eastern Daylight Time on March 22nd, 2019. So we just want to note that this means that any data submitted before 8 p.m. will automatically be accepted. Please note that this close time has been updated as it was previously scheduled to close at 7:59 p.m. Eastern Daylight Time. We know that this is just a minute difference, so we wanted to highlight this difference because, as I noted, any data submitted before 8 p.m. will automatically be accepted. Anything submitted at 8 p.m. or after will not be accepted. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. So we also just want to highlight a few key dates. So please mark your calendars. The next CMS Web Interface webinar will be held on Wednesday, January 16th, 2019, again from 1 to 2 p.m. Eastern Standard Time. Topics will include the CMS Web Interface Application Programming Interface, also known as the API, frequent measure questions, an overview of the 2018 CMS approved reason requests, and we'll also have a Q&A session. Now I will hand it over to Chris Reinhardt. Thank you.
And thank you. And just forewarning, if I should erupt into a bout of coughing or anything, I'm just coming back off of a couple sicknesses that I had that have been driving me nuts. Okay, can we go to the next slide, please? Last time we were on the call, we spoke about the transition to a new identity management system where we were planning to move away from the EIDM system to a new system that we'll refer to as HARP. That migration took place on December 19th. We migrated approximately 72,000 users over from EIDM into QPP HARP. Essentially, this should have been seamless to most people. If you had previously had an account in EIDM and had previously logged into QPP, that account should have migrated over, and you should have not noticed any lapse in service. We do recognize that there were some issues to some individuals that their migration was not complete, and a number of you have probably already contacted the help desk and have open tickets or have already had those tickets resolved. I just want to let you know that we are aware of those. As long as you have a ticket open, we're aware of those issues and we're working to complete them. I do want to note one issue that I just found out about today that I wanted to call out, is that there's reports of once you are able to log into QPP and you do go to your eligibility and reporting screen and you attempt to access the web interface, there's an error message saying we cannot currently access CMS web interface for this APM entity. That's new on our roster today for investigation, and we'll be supplying you with more information as we resolve that issue as well. I just wanted to call that out in case you're experiencing that or you experience that in the next day or two. So anyway, the migration went well for the majority of people. The main difference that we'll have is if you were to register for a new account, the roles have changed. We've minimized the roles. So previously, when registering through EIDM and the PVPQRS application, there was a number of roles that you could select. We've reduced that to 2 roles. You can either be a staff user or a security official. And if you are setting up an organization for the first time, you would become the security official for that organization. If you were attempting to get a role within an organization that already had a security official, you'd select one of the 2 roles, and that existing security official can approve that role for you. It is possible that you would want to have more than one security official, so that's completely doable. Once that first security official is established, you may request a second security official, and that first security official would be the approver for that. Can we go to the next slide? There is information available on the QPP website. So if you log into QPP and go to the resource library, there's documentation in there for. There's actually 4 documents that are in there to help assist you with the new CMS identity management system. One's before you begin. The next is registering for a HARP account. Next is connecting to an organization, and the last is for security officials to manage access for others. So the before you begin is just a general FYI document that'll give you a little background. Registering for a HARP account is very similar to the EIDM process for registering for an account. It's just a slightly different application and user experience for you. But essentially, you put in your user information, your name, address, phone number, details like that. Then you would go through an identity proofing process with Experian to confirm that you are who you are. We need to do that for security purposes. And lastly, you'd you'd select your the means by which you'd want to receive your security token, so that when you log on, for instance, you could get a text with that security token as your third form of authentication. Can we go to the next slide, please? And this is just some information about if you should have any problems, you can contact the Quality Payment Program for assistance with any of those problems. And I'll be searching through the question and answers here for any questions you may have pertaining to the identity management. Thanks.
Good afternoon. I'm Azam Tassel. I would like to show you the changes in PREV10 reporting, deleting entered data, and resolving upload errors via Excel. Next slide, please. This year, PREV10 measure works differently than previous years. You will still receive just one sample of up to 616 beneficiaries for the measure, and those beneficiaries will be calculated in 3 populations. Each beneficiary counts in all 3 populations. Population 2 performance rate is used to determine your PREV10 measure score, and the remaining population's performance rates are displayed in the web interface for your information. Next slide, please. Although there are 3 populations in PREV10, the questions you need to answer for the populations repeat. In order to simplify reporting, you will only answer these questions once through your preferred CMS web interface submission method, such as manual entry, Excel upload, or API, and the data will be synchronized for all 3 populations. Below the PREV10 title, you will see a note that states the measure contains duplicate questions that have been synchronized. As you answer each question in this measure, for example, is the beneficiary qualified for this measure? On the right-hand side of the screen, a message will be displayed that your answer to this question will be used for calculations across populations 1 and 3. Next slide. The next question was the patient screened for tobacco use at least once during the measurement period and year prior to the measurement period. Again, as you answer this question, on the right side of the screen, the message displays your answer to this question will be used for calculation across populations 1 through 3. Next slide. The following question was the patient identified as a tobacco user during the most recent tobacco use screening. And on the right-hand side, again, the message displays your answer to this question will be used for calculation across populations 2 and 3. The last question is, did the patient receive tobacco cessation intervention? And the message displays your answer to this question will be used for calculation across populations 2 and 3. Once all the questions have been answered, on the left side of the screen, you can see that the beneficiary is marked complete and you're done reporting for this beneficiary for all 3 populations. Next slide. The View Progress page will only show your progress for population 2, since population 2 is used to determine your PREV10 measure score. To see all 3 populations and how your beneficiary sample is counted in each, you can access the measure rates report on the View Reports page. You can view the PREV10 instructional video listed here for more information on this measure. Next slide. Deleting entered data. CMS Web Interface allows you to clear reported data for a given beneficiary if you've made a mistake or need to start over. There are two ways to delete reported data. If you're using the Excel upload to submit data, you can remove reported data by selecting NA for a field in the Excel file and upload the file again. Next slide. You can also delete reported data for a beneficiary from the CMS web interface manual data entry screens. Please note that any deletion of data using either of these methods are permanent and cannot be recovered. To delete data via manual data entry, click on Choose Data to Delete link on the left side of your screen. Next slide. Then select Beneficiary Confirmation or a measure data to delete. Then click on Delete Data button. Next slide. Now I will go over resolving errors via Excel. Once your Excel file is uploaded into the system, you may find errors in some of your beneficiary data. The system will not update the measure data for which errors are found. You will need to re-upload or manually enter the data to fix the error. If the last Excel file uploaded contains any errors, on the Report Data page, under the Excel Errors tab, you can see a list of Excel errors. You can resolve these errors manually via another upload or via the API. If the Excel file upload doesn't contain any errors, there will not be an Excel Errors tab displayed on this page. Also on this page, you can download your Excel beneficiary sample template with errors by clicking on Download Errors in Excel button. Next slide, please. Here you can see a sample Excel file with the errors highlighted in the cells that error occurred. Column A of this file will identify in red how many errors are in each row. Each cell that has an error will be colored red for ease of locating and correcting data. You can then edit data in the spreadsheet and re-upload it to the CMS web interface. You can view the 2018 CMS web interface Resolving Errors instructional video for more information. Next slide, please. Now I'm going to pass it off to Angie.
Hi, good afternoon. This is Angie Stevenson with the PIMS Measures team, and I'd like to review some of the frequently asked measures questions that we receive at the Quality Payment Program. Okay, the first slide. This is a common question that we receive regarding the in-hospice program level exclusion. Please clarify what constitutes non-hospice patients receiving palliative goals or comfort care. The patient confirmation instructions state to select in-hospice if the patient is not qualified for the sample due to being in hospice care at any time during the measurement period. This includes non-hospice patients receiving palliative goals or comfort care. The answer, this refers to patients that are not admitted into a hospice program but are receiving palliative goals or comfort care. Please refer to the patient's medical record to determine if the patient was in hospice or received palliative or comfort care at any time during the measurement period. If so, then select Not Qualified for Sample during the patient confirmation step. The CMS web interface will automatically skip any patient for whom Not Qualified for Sample is selected in all measures into which they've been sampled. If you question whether or not the patient is receiving palliative goals or palliative or comfort care, we recommend you reach out to the group or the eligible clinician to determine the meaning of the notes in the medical record. Next slide, please. Question 2 is regarding telehealth encounters. Regarding the web interface quality measures, where it states telehealth encounters are not allowed, what type of encounters qualify for this? Answer, telehealth has not been narrowly defined by CMS for the purpose or manner of collecting numerator information for the 2018 CMS web interface measures. Telehealth visits for the CMS web interface measures that allow telehealth are not required to be Medicare reimbursed telehealth visits. Information can be obtained from the patient over the phone, email, etc. Medical record documentation of the information that was obtained and the date of the telehealth visit is required in the event of an audit to support what was reported. The 3 measures that do not allow telehealth for submitting numerator information for 2018 are HTN2, PREV9, and PREV13. Next slide, please. Question 3 is for Care 1 medication reconciliation post-discharge. What documentation is required to confirm that the medication reconciliation was performed? Answer, please see the definition of the medication reconciliation on page 5 of the Care 1 measure specifications. Documentation in the outpatient medical record must include evidence of medication reconciliation and the date on which it was performed. Any of the following evidence meets the criteria. These are listed on page 5 in the measure specifications. So the first one is documentation of the current medications with a notation that references the discharge medications, such as no changes in meds since discharge, same meds as at discharge, or discontinue all discharge meds. Number 2 is documentation on the patient's current medications with a notation that the discharge medications were reviewed. 3 is documentation that the provider reconciled the current and discharge meds. 4 is documentation of a current medication list, a discharge medication list, and a notation that the appropriate practitioner type reviewed both lists on the same date of service. Number 5, notation that no medications were prescribed or ordered upon discharge. Number 6, documentation that the patient was seen for post-discharge follow-up with evidence of Medicare reconciliation or review. And 7, documentation in the discharge summary that the discharge medications were reconciled with the current medications. The discharge summary must be in the outpatient chart to be included. Next slide, please. Question 4 is, we have an integrated electronic medical record, so our discharge medication list is actually the same medication list that our providers see in the ambulatory setting. The providers check the box indicating that the medication reconciliation was completed, which means they reconciled the current medications with the discharge medications. Is this acceptable? Answer, if the EMR page provides information to support one of the scenarios shown under the definition of the Medicare reconciliation on page 5 of the measure specifications, it will meet the intent of the measure. In the example, if checking the box indicates that the discharge medications were reviewed, then this would meet criteria 2 and would count as performance met. Criteria 2 then is documentation of the patient's current medication with the notation that the discharge medications were reviewed. In the event of an audit, you must have a documented policy in place that outlines exactly what the provider was attesting to when checking the box. Next slide, please. Question 5 is, can you clarify that the discharge medications need to be reconciled by the physician, practitioner, registered nurse, or pharmacist? Can an LPN do the reconciliation? Answer, the intent of the measure is to ensure that the physician, prescribing practitioner, registered nurse, or clinical pharmacist providing the ongoing care reviewed the discharge medications from the inpatient facility. If an LPN or others perform the reconciliation on behalf of the eligible clinician, there must be documentation that the physician, prescribing practitioner, registered nurse, or clinical pharmacist providing ongoing care is aware of the review. You can find this in the numerator guidance note on page 9 of the Care 1 measure specifications. Question 6, is it acceptable to complete the Medicare reconciliation by phone? The answer is yes, as long as there is evidence of medication reconciliation and the date on which it was performed documented in the medical record, and documentation the physician, prescribing practitioner, registered nurse, or clinical pharmacist providing the ongoing care is aware of the review. Please see the numerator guidance on page 9 of the Care 1 measure specifications, which states medication reconciliation post-discharge may be completed during a telehealth encounter. Next slide, please. Question 7 is for the Care 2 Falls Screening for Future Fall Risk measure. For Care 2, the exclusion states that if the patient is marked as non-ambulatory during their most recent encounter, that they can be excluded from the measure. What if the patient is wheelchair-bound and has been marked as non-ambulatory by their PCP during a visit, but later has a dermatology visit as their most recent encounter that does not have the patient documented as non-ambulatory? Are we able to use the most recent PCP encounter? Answer, no. There must be medical record documentation that the patient was non-ambulatory at the most recent visit in the measurement period, whether it was a PCP or dermatologist or any specialist visit, in order to be excluded from the measure. Please see the denominator guidance on page 7 of the measure specifications, which states that the denominator exclusion is to count as non-ambulatory only if non-ambulatory at the most recent encounter during the measurement period. Thank you, everyone. I'll turn it over to Lisa Marie Gomez.
Great, thank you. So the next few slides that we have will outline the available CMS Web Interface resources. I just want to note that the resources, all of the resources that we'll go through, there are links that we provided to you in the pop-up box within this webinar. So if you want access to the links immediately, just go to the pop-up box and you will get those links right there. Next slide, please. So the items currently listed on this resource slide, as well as some of those mentioned earlier in the presentation, all of these resources are available within the Quality Payment Program Resource Library. And we'll communicate any future postings and upcoming webinars in these webinar presentations, but also in our announcements that we send out to our users. All right, next slide, please. I just want to highlight that the help and support page at qpp.cms.gov contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. We have also provided the links to the Quality Payment Program webinar library, where you can find all the materials from the previous CMS Web Interface webinars. Again, we just want to be as helpful as possible and provide you with the resources as you go through our webinars, but also as you're going through reporting. I also just want to note that, as previously mentioned, the CMS Web Interface instructional videos are now available, and this slide will also contain the link to the playlist containing all the videos, as you can see right there at the end of the slide. All right, next slide, please. This slide contains links and resources to any information that you would have with regard to the Medicare Shared Savings Program and the Next Generation ACO Model Program. So these are the links and information that will be helpful to you as you go forward and report. So right now let's go to the next slide. So this slide contains contact information for requesting additional assistance if needed. Now I'm going to turn it over to Michaela for the Q&A session. Thank you, everyone.
Great. Next slide, please. We're now going to start the Q&A portion of the webinar. You can ask questions either via chat or via phone. To ask a question via phone, please dial 1-866-452-7887. And if prompted, please provide the conference ID number, which is 146-4209, and make sure to press star 1 to be added to the question queue. So our first chat question is the sample available on the web interface now the final sample?
Hi, this is Sarah Growler from RTI. Yes, that will be the final sample, the same sample that will be available on 1/22.
Great, thank you. And then for this next question, this person just wanted to clarify that the CMS web interface opens at 10 a.m. on the 22nd. Is that correct?
This is Lisa Marie, and you are correct. It does open at 10 a.m. Eastern Standard Time. Yes.
Great, thank you. This next question is, will the partial government shutdown affect anything regarding this year's submission?
This is Lisa Marie. At this juncture, we have not been provided with any guidance indicating that there would be an implication or an impact to the web interface during the government shutdown. As of now, everything is open even during the shutdown. As you all know, you're in the test period right now for the web interface. So as of now, the answer is no.
Great, thank you, Lisa Marie. And this next question is there any bonus for submitting via the Excel file as it was last year for this performance period?
Hi, this is Azam Tassel. Yes, you will receive 1 bonus point for each measure that was updated via an Excel upload or an API.
Great, thank you, Aslam. And Stephanie, do we have any questions on the phone lines?
We do have a question from Jason Shropshire.
Hi, can you hear me?
Yes.
Yes, for all the measures, can you please confirm a denominator exception, is that included in the count of 248, or do you have to skip those and go on to the next patient?
So I can begin to answer this question. This is Sarah. A denominator exception will be skipped but not replaced, whereas an exclusion is skipped and replaced.
Is that or is that not included in the 248 count, meaning we don't have to go beyond that count? If, let's say, we had 243 and we had 5 denominator exceptions.
Aslam, would you be able to speak to what is in the minimum?
So the denominator exceptions will be marked as complete, and the beneficiary will not be marked as skipped. And in the web interface, your minimum reporting requirements will be clearly displayed, and as you answer beneficiaries, you will see if the minimum requirement goes from 248 to 249. It'll be clearly displayed to indicate that you have not met the minimum yet.
Okay, so, and again, I asked for clarification. Can you just say yes or no they're included? Because I don't have the template in front of me. I just want to know if we have to include those in the count or not.
Can we come back to
I don't want to misrepresent. So if you would like to open a help desk ticket, we can clearly look at the scenarios you're identifying, and we'll be able to respond to you more accurately.
Great, thanks.
All right, and our next question is, where are the Excel spreadsheets located?
Will you be able to answer that question with regard to where they find the Excel template?
If the question is regarding downloading their Excel file, once logging into the web interface, you can navigate to the report data page. And on the report data page, you will see an area to download the Excel file, and there are two options. You can download it with data or without data. Both options are available on the report data page.
Great, thank you. This next question is, when initially qualifying a patient and thinking about the HMO exclusion, is it only if HMO is primary?
This is Amy Mills. I can answer that. Yes, you should only select that option if Medicare fee-for-service is not the primary payer.
Thank you. This next question is, for the tobacco measure, how is the information split into the three populations?
Hi, this is Angie with the PIMS Measures team. I can answer that from the measure perspective. It's going to be based on the questions that you're answering in the Excel template, of course. And you will answer the questions, and then population 1 the numerator would be patients who were screened for tobacco at least once within 24 months. The numerator for population 2 would be patients who received tobacco cessation intervention, because those would be those that were identified as tobacco users for population 2's denominator. Population 3 are patients who were screened for tobacco use at least once within 24 months and who received tobacco cessation intervention if identified as a tobacco user. That population also includes patients identified as non-tobacco users.
Great, thank you. This next question is also related to the tobacco measure. What constitutes other medical reasons under the exclusions, and can you provide an example?
Hi, this is Angie from PIMS again. You can find that information on page 5 under denominator exceptions in the specifications. Population 1's medical reasons are reasons for not screening for tobacco use. An example is limited life expectancy. Other medical reasons similar to that would be at the discretion of the eligible clinician. Population 2, I guess that is the same, and I'm not answering your question completely. Other medical reason. It would be something that the eligible clinician would consider the reason for not screening due to medical reasons. Does anybody from any of the other teams have something they can add to that? If you would want to submit a request to the Quality Payment Program, then we can give you a better answer. Thank you.
Thank you, Angie. And Stephanie, do we have any more questions on the phone?
No questions at this time. If you would like to ask a question, star and the number 1 on your telephone keypad.
All right, so our next question in the chat is for the PREV-12 measure. Does situational depression count under the denominator exclusion?
Hi, this is Jessica from the PIMS Measures team. When I look at the 2018 CMS Web Interface PREV coding document, I do not see a diagnostic code that is titled situational depression. So in short, I would have to say no, but you would need to look at that 2018 CMS Web Interface PREV coding document for the list of exclusion codes to determine whether or not that patient's diagnosis would count for an exclusion. Thank you.
Thank you. For this next question, for the colorectal cancer screening measure, if a patient was an inpatient in a longer-term care facility any time during the measurement period and gets discharged, does that mean we exclude the patient?
This is Jessica again. So on page 5 of the measure specification, under the denominator exclusion section, it indicates that patients age 65 and older in institutional special need plans or residing in long-term care with a place of service code 32, 33, 34, 54, or 56 at any time during the measurement period would be excluded. So you would unfortunately need to just double check that med record for indication of what type of, whether or not their long-term care falls within those place of service codes, and if so, then you may exclude them. Thank you.
Thank you, Jessica. This next question is about the influenza immunization measure. Do patients have to have 2 confirmed doses before the age of 9?
Hi, this is Angie from the PIMS Measures team. No, that is not a requirement of the measure. For reporting the denominator, if that's patients seen between October 1st of 2017 through March 31st of 2018, you would just need to determine if the patient received an influenza immunization or reported previous receipt of the immunization between August 1st, 2017 and March 31st, 2018 to report the numerator. Thank you.
Thank you. This next question is for IVD2. What does use of anticoagulant medications overlapping the measurement period mean? And then this person says, last year it was stated that any use of an anticoagulant during the measurement period qualified as a denominator exclusion. Is this also true for 2018 reporting?
Hi, this is Angie from PIMS. The use of the term overlapping in the specification means that the initial diagnosis of IVD did not have to occur during the measurement year, but an active diagnosis of IVD must be found during the measurement year. Likewise, the denominator exclusions, the initial prescription for an anticoagulant does not have to have occurred during the measurement year, but the patient record should reflect that the patient is on an anticoagulant during the measurement year. And yes, any use of an anticoagulant during the measurement period at all would qualify for the denominator exclusion. Thank you.
Thank you. And this next question is to confirm the testing period ends on January 18th, 2019, correct?
Yes, that is correct. So it's a Friday, and it ends, and then there'll be a 3-day time frame, Saturday, Sunday, and Monday, because that Monday is a federal holiday. It will be closed. And then it will open on Tuesday, January 22nd for the actual submission period. But you are correct. The test period closes on the 19th of January.
Great. Thank you, Lisa Marie. And Stephanie, do we have anyone on the phone with questions?
We have 3 questions. Our first question is from Molly Nichols.
Hi. My question's regarding the PREV-10 measure. I knew the statement was made that each patient counts in all 3 populations. I was just looking for clarification on how does a patient that is identified as a non-tobacco user, so screened, step 1, patient screened, step 2, not a tobacco user, do they count in population 2?
Hi, this is Aslam. If I can clarify that statement, you will not receive a separate beneficiary sample for each population. You will only receive one beneficiary sample of up to 616 beneficiaries, and that beneficiary sample will be used to answer questions for populations 1, 2, and 3.
So I think the question is still if around the statement that you guys had on the slide, for each patient counts in all 3 populations, does a patient that is a non-tobacco user, do they count in population 2? I understand there's only one sample. I'm just trying to understand how each patient counts in all 3 populations.
Laura, will you be able to answer this question?
Hi, this is Angie from PIMS. Only tobacco users are included in the denominator for population 2. So,
okay, so if there was a patient who was a tobacco user, who was not a tobacco user, they would not be in the denominator for population 2.
Correct.
Thank you.
Thank you. Our next question is, we noticed there were a number of missing provider 1, 2, 3 NPIs on the beneficiary sample list provided on the web interface portal.
This is Olivia. So I see this question is from an ACO, and for ACOs in particular, this top provider information, provider and clinic in the CMS web interface is populated using your ACO's Quarter 3 assignment list report, and as you may know, the providers in the Quarter 3 assignment list report are limited to certain specialties used in assignment. So the beneficiaries in the CMS web interface who do not have a provider listed are likely those prospectively assigned beneficiaries or voluntarily aligned beneficiaries or regularly assigned beneficiaries who do not have primary care services from a specialty used in assignment, but have at least 2 primary care services overall, kind of regardless of the provider specialty, and are thus still eligible for sampling into the CMS web interface. I hope that clarified.
Yeah, thank you, Olivia. This next question is for depression screening. If a patient scores 5 or higher, but a physician states the patient is not depressed in the visit note, would this be enough to say that the patient does not need a follow-up plan for depression and is a negative screening?
So, sorry if I'm breathing in the phone. So the short of it is, if that provider's note means that the patient was assessed and they are not depressed, then that would count. On page 11 of the spec, it states whether or not a standardized screening tool is considered positive or negative would be determined by the professional administering and reviewing the tool. I'm not able to transcribe the medical record notes. If you come across medical record notes that you're not sure about, you're absolutely welcome to reach out to the provider for clarification. In short, if you have medical record documentation saying that the provider assessed them and reviewed it and they are not depressed, then that would count. But if there's something else in that documentation that you're concerned about, please reach out to the provider. There are situations where they might score high on a test, but after further examination by the doctor decides that they are not depressed, and vice versa. there might be a patient who comes into the ER for a suicide attempt, but they tell the doctor they're not depressed. I mean, there might be just situations in which the doctor's interpretation will trump what you see in the tool score. If you have any other questions, please do reach out to the help desk. Thank you.
Thank you. This next question is, on the sample data that we've downloaded from the web interface, there are yes answered on Prev 7 for the question, did the patient receive a flu immunization? Where is this coming from, and can it be considered correct?
Hi, this is Sarah from RTI. Those pre-populated answers are coming from claims data, so where there was evidence from claims that a flu vaccination was given, that is pre-populated in the web interface. As far as how to confirm its accuracy, I would turn to a measure expert to answer that question.
And I'm sorry, can you please repeat the question?
Yes. So this person said on the sample data that they downloaded from the web interface, there were some yeses answered on Prev 7 for the question, did the patient receive a flu immunization? So they were just asking, where is this coming from, and can it be considered correct?
Hi, this is Angie with PIMS. Yes, I believe on the question and answer document that was posted on QPP, there is a question about that. And if Prev 7, if it is pre-populated from claims that the immunization was received, then you do not have to verify that that is true. It'll be considered as meeting the intent of the measure.
Great, thank you. And Stephanie, we can take one of the phone questions at this time.
Our next question is from Trudy Garrissey.
I'm withdrawing my question.
Thank you.
Okay, thank you.
Our next question will be from Ingrid Enamorado.
Hello.
Go ahead, Ingrid.
Yes, question for Care 1. Does telehealth count as meeting the office visit requirement?
Hi, Ingrid. This is Jessica Schumacher from the PIMS team. So, yes, telehealth does count if during a follow-up phone call if there's documentation of reconciliation, then that does count. And I did provide an excerpt via the service center case.
Okay, great. Just because last year we were told that it did not count. So if a provider states that they did a telehealth, the patient does not need to physically go into the office. That is correct.
So, and I reviewed the 2017 language that you submitted, and in that language there was evidence that a telehealth does count last year as well.
Great, thank you.
All right, thanks.
All right, this next question is, in the training environment, do the claims data pre-populate as complete?
I'm not sure what the question actually is. If this is in reference to the claims data for Prev 7, I'm assuming that, yes, they would be pre-populated as yes, receiving a flu vaccination. I'm not sure if that's the question or not.
Okay, thank you. And this next question is, what do we do if the date of birth for a beneficiary is different in the sample file sent from CMS than what it is in the medical record?
This is Olivia Burton. I can answer that. So while the CMS web interface user can modify the demographic information that is populated into the CMS web interface, things like the date of birth or gender, for instance, that beneficiaries' demographic information doesn't get fed back to the source. So we'd encourage you to encourage the beneficiary to potentially contact the Social Security Administration if the data that we have populated for you is not correct. So that's at least from the demographic perspective. I don't know if others want to speak to things like diagnoses in the CMS web interface.
Hi, this is Aslam. If I can add to it, if the data that you're referring to is, for example, date of birth or first name, last name, gender, those demographic information can be updated within the web interface using the data entry pages.
Great, thank you. And I think we have time for one more question. So this last question is for Care 2 Falls. Does the documentation of steady gait in the medical records satisfy the measure for a pass?
Hi, this is Jessica, and I saw a couple questions come through the Q&A box that are kind of similar to this. And for Care 2, CMS allows the eligible clinician or group to determine the level of detail for their gait or balance assessment. So as long as there is documentation that an assessment was conducted and they're finding, for example, a steady gait, as you mentioned, or gait within normal limits, or their gait is unsteady, then that type of medical record documentation, as long as it's during the measurement year, would be considered a false screening. The Care 2 spec does provide suggestions for like the Morse Falls Scale and the Get Up and Go. There are some suggestions of types of tests that can be used, but again, it's not required. So if your provider provides that assessment, and it's in the medical record documentation for purposes of an audit, then that would count. Thank you.
Great, thank you. And that is all the time we have for today, so thank you all for joining. If we weren't able to answer your question, please do feel free to email those addresses for help with the Quality Payment Program, the Medicare Shared Savings Program ACO, and the Next Generation ACO. We did share those emails on a previous slide and also sent them out as an announcement that you should have seen pop up on your screen. And we also encourage you to join us for our next webinar next Wednesday on January 16th. So thank you, everyone.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.